Good morning. I would like to thank the organizing committee and Professor Adel Hamed for the kind invitation and Ahmed Hegazi from the Status Clinic. So I will talk about the use of stem cells in treating the cartilage lesions of the knee. It will be more science data rather than clinical. So what we already know with injury, there is poor vascularity, which limits the healing potential. So a lesion like that, it will end to arthritis. We know this study from Dr. Kerr back from Duke about the prevalence of these injuries. So the symptoms are very well known to all of us. So what are the goals of cartilage restore, the smooth articular so as to relieve patient symptoms and improve function of the knee. And the overall goal is to prevent progression to end-stage arthritis. So these are the treatment options that we have. So you can go from debridement and lavage as a primary treatment. Then you can use microfracture, or you can totally restore the surface using either auto transfer of osteochondral grafts from the other part of the knee, or you. In this slide, we present the strength limitations of its technique. So we all know that if you use only microfracture, after 2 to 3 years, it deteriorates the repair tissue, so you have symptoms again. If you use mosaic plasty, donor site morbidity, and sometimes it's very difficult to restore the joint congruity. About the ACI, it's an open technique, it's expensive technique, two-stage technique, so you cannot always use it in every country. Newer techniques, a favorite one back in the time of Atos, AMIC, using the porcine collagen pads to enhance marrow cell stimulation with the use of microfracture. So, all of these scientists that head into cartilage repair, they try to yield. So the questions are, what is the most effective and available cell source? What is the best scaffold to use? Should we use proper growth factors? And what about the technique that we use? Is it minimally invasive? Is it cost effective? And what about the success rate? So here comes the so-called tissue engineering to give such an answer. So we can use stem cells in combination with a scaffold, and all of these combined with biological factors in whichever joint you may choose to go to. These are the basic principles of tissue engineering. Market several substrates. This might be made by hitosan or hyaluronic acid or collagen, 1+3 bilayer. What about the cell source? So we try to use adult mesenchymal stem cells. As we all know, these are multipotent, so these are capable of producing cells of different lineages. All of them are unspecialized cells. So if you try to cultivate them, they should be plastic adherent, and they should also express these antigen factors, which are very specific, these HLA-DR surface molecules. The question that arises is which one is the optimal stem cell source to do these tissue engineering approaches. Some people, they have used the bone marrow derived stem cells. The decent is the very tissue volume and the low cell volume. Also, the aspiration is a painful procedure. What about adipose tissue derived stem cells? This is more easier to get because you can use liposuction. So if you try to use the material that you get from the liposuction procedure, this is called SVF, this is stromal vascular fraction. So if you try to obtain pure adipose tissue derived stem cells, So, in this comparison study, they compared the human adipose tissue-derived stem cells versus bone marrow. So it was shown that the bone marrow stem cells, they have an increased chondrogenic differentiation compared to the adipose tissue-derived. But if you go and apply certain growth factor like TGF, B2, or BMP6, this can enhance the chondrogenic potential of adipose tissue-derived stem cells to a comparable level to bone marrow. What about if you try to compare bone marrow versus adipose tissue-derived versus synovial membrane-derived stem cells? This is a study from Japan, from Professor Sakaguchi. So he obtained tissues from 8 knee donors, and they have shown that in chondrogenesis studies, the cells that were derived from the synovium, they were shown to be larger pellets, and they stained more extensively for cartilage matrix. This is a study from our team in Athens. So we tried to do the same thing, but in rabbits. We used 10 female New Zealand white rabbits, and we've drawn bone marrow using an aspiration needle. We've taken all this adipose tissue, synovium, patellar tendon, harvested from the knee joint, and we have shown, and it was published in Injury recently, that the synovial stem cells during chondrogenesis express twice the amount of aggrecan than cells from the other sources, and they also exhibited larger size of pellet cultures. So for those that are interested into basic science study, it seems that using synovial membrane-derived stem cells has a better chondrogenic capability. What about the clinical evidence? Are there any studies out there using stem cells? So there are some of these. There is a study using bone marrow-derived stem cells for chondral defects in the knee. Small numbers, you see 5 patients. But they have shown that after a year, all the symptoms have gone, all the scores are very good, and the MRI has revealed that there is a complete fill of the defect with complete surface congruity with native cartilage. Another study, big one, with 72 patients, split into 2 groups, one with ACI and one with bone marrow-derived stem cells. Both clinical evaluation and evaluation with clinical scores. There was no difference between the ACI and the bone marrow stem cells in terms of clinical outcomes. Another study from Koch and al. With 18 patients using adipose tissue-derived stem cells. The adipose tissue was harvested from the knee fat pad instead of the belly. And they have shown that all of the patients, they were improved in both clinical and MRI results. Another study from Japan using synovium-derived stem cells, small number again, 10 patients from Professor Sekiya. They have shown that in second look arthroscopy and the biopsy specimens which were evaluated histologically, there was a complete fill of the defect, and the histological analysis showed hyaline cartilage in 3 patients. So what are the future perspectives of using this evolution in tissue engineering of the cartilage? We have this so-called 3D bioprinting technology, which is out there. Me personally, I was at Wake Forest, North Carolina, which I first saw this technology being applied to. It's a very nice one because you can use cells with a hydrogel, and this is a bioprinter. You can create small pieces of cartilage using your own preference of cells. This comes from Australia, the so-called BioPen. They use adipose tissue-derived stem cells. It's a handheld pen, which is capable of doing this 3D printing cartilage tissue. And they use a hydrogel material as a scaffold to try to compare to natural cartilage, articular cartilage. So from this talk, what you can take from as a home message is that the use of stem cells is increasing in both animal and clinical studies. From the animal studies, you can see that the synovium-derived stem cells, they have the greatest chondrogenic potential compared to bone marrow and the adipose tissue-derived ones. There is currently limited evidence of a direct clinical benefit, but I know there are many clinical studies out there ongoing, both in the US and Europe as well. So further research is required to see the overall outcome of stem cell therapies for cartilage repair. Thank you for your attention.
Thank you very much.